Do you think you've mastered neurology? Let's put your knowledge to the test.
This image outlines the clinical features of Parkinson Plus syndromes labeled by column. Each column corresponds to a different syndrome. Match each number in the image to the correct diagnosis.
They're all Parkinsonisms. So all four of these conditions present with bradykinesia, rigidity, and postural instability. With Lewy body dementia, we see early dementia as a prominent feature in those patients. So dementia begins within 1 year of the development of Parkinsonian symptoms. We can also see hallucinations in these patients, and neuroleptic sensitivity is common. We use neuroleptics to manage some of the symptoms we can see when patients are hallucinating or agitated, and these patients will develop severe sensitivity and become agitated and confused and may need hospitalization as a result of initiation of neuroleptics. Next, multiple system atrophy. The key features to this syndrome is early autonomic dysfunction. So we think about orthostasis, erectile dysfunction, and incontinence. And early findings, any of those three findings early in the course of the Parkinsonism should prompt the consideration for multiple system atrophy. Next, let's talk about progressive supranuclear palsy. The key things we see there are twofold. One is down gaze impairment. So these patients have early vertical down gaze palsy. They can't look down. As a result, they have frequent falls, and we see falling. In Parkinson's disease, falls are late, and PSP falls are early. This is also an axial, akinetic, rigid Parkinsonism. So patients have difficulty moving, and they are very, very rigid, often in the axial musculature that controls our posture and axial tone. Patients may have other brainstem symptoms, dysphagia or oral dyskinesias, or dysphonia. And then lastly, corticobasal degeneration. This is a really unique and kind of strange, uniquely strange syndrome. Here we see that it's prominently asymmetric. Patients begin with very asymmetric symptoms, and we see a few things: apraxia, alien hand, and cognitive deficits. And this owes to its predilection for the parietal lobes. Apraxia is motor planning. So these patients are able to move, but they just can't form the plan for how to do it and what they need to do.